So Dr. Gupta is going to come back and talk to us now about the application of Neuro Perfusion, which of course has been in the media quite a bit. It's been on scanners for a while, but until the technology got as solid as it's been the last couple of years, this wasn't a widely used application. And so I think there have been some obvious growing pains in learning how to use it properly. Oh, it's still booting up. And so while we're still waiting on that, one thing I want to mention, it's been discussed, maybe not explicitly, that the APM is working on a project to actually come up with reference protocols, if you will, for a variety of different scanners and a variety of different applications. And so we started with CT perfusion because after the incidents at a few places, especially out on the West Coast, all of us were getting phone calls from lots of different clinical centers saying, and our physicist said, I was just told to check out my CT perfusion protocols. Can you tell me if it's the right one? And so we thought the most valuable way to communicate to the community was set up this sort of primer. Here's what CT perfusion is. Here's the quality that you're looking for. And then we worked with different users and manufacturers. And so this protocol will be posted on the APM website. Hopefully by the end of the conference or early next week. And what we've gone for the different manufacturers is worked with each of them to say what is a good, reasonable protocol you should use so that then a site can compare what they're doing to that. And, you can always tweak things a little one way or the other, but if they're very different, then you've got to look into it. So that is the first one we started at, and so good. That is working again. So, Dr. Gupta, thank you.
Thank you, Cynthia. Okay, so I'll talk about CT perfusion. And instead of covering only neuro CT perfusion, I'll also be talking about cardiac CT perfusion. So this talk is a little bit schizophrenic because it covers two topics. Okay. So if you look at the top causes of mortality, this is some data from 2005. Almost 700,000 people die of cardiac disease, of which the great majority are from coronary artery disease, which is essentially a perfusion problem of the heart. Most people don't think of cancer as an issue with perfusion, but cancers, besides being rapidly dividing cells, also spawn off their own vasculature. So there is an angiogenesis aspect of tumors, which is well studied, and so there is a perfusion problem even in oncologic imaging. And obviously stroke is a perfusion problem. The majority of the stroke is ischemic stroke, and ischemia by definition is lack of perfusion to some portion of the brain. So CT perfusion has a role to play in the top three causes of death. We just have to make it work and make it work in proper amount of dose, which is what this talk is about. So I'll talk about the application domains a little bit. Stroke imaging, vasospasm is another application after subarachnoid hemorrhage. When an aneurysm ruptures, most people don't really die from the fact that they have so much hemorrhage within the brain. You can put ventriculostomy catheters. You can do other interventions to get rid of that hemorrhagic load. The complications of the hemorrhage is what is lethal to most patients, which is development of vasospasm about 7 to 11 days after the hemorrhage. And we do routinely perfusion imaging for assessing vasospasm. Myocardial imaging is another place where perfusion has a role in tumor imaging. So initially, I'll talk about the basic CT perfusion paradigm, and then I'll sort of divide the overall presentation into two portions: neuro perfusion and myocardial perfusion. Okay. So here we have a head CT that I showed in the previous talk. As I said earlier, we have the cortical ribbon over here, but over here there is a deficit in perfusion. Okay, here is a myocardial scan. It's a short axis. This is the left ventricle. This is all the myocardium around the heart. Some of the projection is not that great. I don't know if you can appreciate the fact that all this myocardium is kind of dark while the myocardium should really look more like this color. Okay, so there's an old infarct probably which is causing a perfusion deficit. Okay, so if we took a reference point through here and did imaging over time, let's say we pick this artery or if we pick the left ventricular cavity, we'll get a curve that looks like this. Okay, you have the initial non-contrast phase, then the bolus comes in, and then you have a recirculation phase. Okay. If you look at the portion which is well perfused, for example, this part of the cerebral cortex or this part of the myocardium, you may get a curve that looks like this. There's a bolus arrival time, then the bolus peaks. Maybe there is a little bit of delay from the reference standard because it is later in the circuit. But you'll get a curve that looks pretty much like the original curve, but a little lower. If you put another curve over here, which is in the portion that is underperfused, for example, this myocardium or that part of the cortex, what you'll see is further lowering of the amount of contrast that is coming in, and also maybe a delayed arrival. So that is what the perfusion imaging is about. We are trying to see the difference between these two curves and quantify them somehow in order to derive parameters that will tell us how much is the perfusion deficit. And there are multiple terms that are being that are used here. So if this is your time of pacification curve, people say, well, the area under this curve is the amount of overall contrast that got into that voxel. So that must be the blood volume or the tissue volume. This is the amount that from here to here is how much is the transit time through that voxel. So that is called the MTT or the mean transit time. And if you take the cerebral blood volume divided by the mean transit time, you'll get a measure of the flow through that voxel. So that is CBF. Okay, there are surrogate measures. You can measure how much is the slope of this what is the upslope. Faster is the arrival, higher is the flow, higher is the slope. You can also look at the time to peak. If there is no excessive delay, the time to peak becomes a measure of your transit time. Okay. So people have done sort of the basic homework. If the amount of iodine concentration in the tissue is directly proportional to the Hounsfield unit, so what we are measuring is correct. It is the amount of blood that is getting into that tissue. If you use other modalities like microspheres and measure the blood flow, and then you measure the blood flow using CT, you find very high correlations. So there is good confidence that the numbers that we are measuring are something physiologic, that they represent the basic physiology of blood coming in and leaving that voxel. If you take the reference standard, here is some cardiac data that was presented. If you took the normal myocardium and if you took ischemic myocardium, the ischemic myocardium is slightly delayed. And if you quantify this effect, these effects are statistically significant. What that means is that our CT data sets have enough resolving power to be able to see those small differences. Okay. But you really have to squint very hard to see these small differences because the amount of data that we're getting is very, very low. So some basic physiology. The blood vessels maintain flow up to a very high degree of stenosis. So here we have percent stenosis in a blood vessel. Here is the blood flow at rest as well as at stress. Unless the stenosis becomes very, very significant, you do not see the effect of that stenosis on the flow. And you bring out the effect faster when the muscle or the organ is stressed. And that fact is used very often in cardiac imaging. So what you do is you typically would do a rest imaging, and you, if this is hemodynamically significant, this side will be getting less blood flow. That is one way you can image ischemic myocardium, and this is the mode that is used in all neuro imaging. So when somebody comes with stroke and you want to do perfusion imaging, obviously you're only doing rest imaging. You're not doing any stress imaging. In cardiac perfusion, you also give either pharmacologic stress or you exercise the patients, and then you can accentuate the effect of lack of blood flow. So what happens is this vessel would dilate, but this vessel would not dilate, or at least the portion that is stenosed would not dilate, and you would have preferential flow through this side. Okay. Also, if there is a collateral vessel, you may reverse the flow within the collateral vessel, and you can start additional steal phenomenon. Okay. So these are the two features that are used for cardiac perfusion, which accentuate the perfusion deficit. Okay. So the main challenges in perfusion imaging are, first of all, there are too many technologies. So you have to sort of determine how to use a particular modality in order to do proper cardiac perfusion or proper perfusion in general. So there are many CT scanners, there are many processing algorithms, there are lots of papers out there that try to quantify what are the right thresholds and so on. There are papers out there that say that different vendors don't quite agree on their algorithms and the number of the actual data that is being generated. So you've got to filter through all that noise and sort of on your scanner figure out a protocol that works. Okay. Generally, as I said, the contrast to noise ratio and the signal to noise ratio is very, very low. Okay, and I'll give you an example of how low that is. Okay, and the dose can be very high, and that has been in the news lately. To me, that was sort of a user error, and to some extent, we have sort of focused in on an aspect of CT perfusion that is manageable. The big research questions are: once you are doing a perfusion which is done within the dose bounds that have been set up, how do we use that data robustly? Okay. And then the clinical applications are still being worked out. So we do fair amount of perfusion imaging, and we're still sort of figuring out as to how can we use that data on a routine basis. Okay. So other than that, life is good. so there are all these challenges, and I'll sort of walk you through all these challenges. Okay. So first thing about CT technologies, and it was very nicely illustrated by the previous speaker, as to there are these various modalities that are available. There are single source images, single source scanners, where you have to sort of spiral your way through, maybe do retrospective gating, bin your data into proper bins, and then do the reconstruction, multiphasic reconstruction. These are widely available, but they are slow, and there is poor Z-axis coverage. Then there are dual source scanners. Again, they are fast, but the Z-axis coverage can be a challenge. And also there is a time gap between when you scan the bottom of the heart and when you scan the top of the heart. Okay. There are these wide area scanners, as illustrated over here, that can cover the heart in one rotation. And then there are the second generation dual source scanners that can do very fast, high pitch cardiac scanning. Okay. And so in the Neuro scan, if you have only a limited coverage and you want to scan over time, you can do 1 or 2 slabs, which is what we do routinely on our 64-slice scanners. If you happen to have a wide area coverage scanner like this, 320i or something, then you can do a full head scanning, full head perfusion scanning. Okay, so these are some of these pros and cons that are listed over here. So this was a movie that I made, actually, but I couldn't get this movie to play, so I'll just give you some static snapshots from this movie. So here, there was a perfusion scan that was done. This was the baseline scan, and you see a 36 Hounsfield unit sort of over here. If you were to track this area as the bolus comes in and goes out, this is the type of curve that you will get. Okay, so the difference between here, you are going from maybe from 35 Hounsfield units to maybe 45 Hounsfield units. So there's a 10 Hounsfield unit difference, and that's all the signal that you have. So I have a very nice movie where I show this wide area coverage, and I play the movie. And people say, oh, wow, this is where the bolus comes in, all the arteries light up, and people are happy. Okay, obviously anybody can do that problem. Then I zoom into this area and make a picture like this. And I ask the people, okay, tell me when the bolus comes in. Okay, and nobody gets it. It's only when you sort of visually average the whole thing that can you find the actual, that 8 Hounsfield unit difference. So that is how subtle the difference is. Okay. So if you were to actually just sit on 1 pixel and do CT perfusion, this is the type of curve you will get. This is still within the noise. This is still within like 1 standard deviation. Okay. In MR, we're a little bit better because the susceptibility of the contrast changes, and that's what we're depending on. Okay, this is what happens in the gray matter. This is what happens in white matter, where the blood flow is lower. Okay, but if you were to thicken the pixels, then this is the type of curves that you start getting, and that shows you why we have these very speckly, large, boxy-looking CTP images. That's because you have to average several pixels in order to derive your data. There's no way around it. Okay. Let's talk a little bit about neuroperfusion. And why do we do neuroperfusion? What is the sort of basic fundamental need for doing neuroperfusion? So there is this sort of central dogma which everybody is trying to prove, which is when the patient arrives, there is already some tissue that is dead. Okay, that is called the core of the infarct. And it's very nicely visible on DWI images, diffusion-weighted MRI scans, except that most emergency rooms don't have MRI scanners. Okay, so that is what is called the core of the infarct. Then, if there is a proximal occlusion, there is a penumbra around it, or there is a much larger area where the blood flow is reduced. So this tissue has already died, but there's a much larger perfusion abnormality, which is the overall tissue at risk. Okay, so if you can figure out early on in the onset of a stroke, preferably within the first 3 hours, that there's a much larger perfusion deficit as compared to the core of the infarct, then you can potentially do something. Okay, and there are therapies that are available for this. Okay, so it's the diffusion-perfusion mismatch, which is what everybody is trying to quantify. Now, a sort of a more radical thought there is, can we do all this work using only a CT scanner? Can we define both the core of the infarct as well as the ischemic penumbra using using CT perfusion? Okay, so this is the core, this is the penumbra, and that is the difference is the tissue at risk. So this is the acute stroke protocol that we use at our institution. Everybody starts off getting a non-contrast head CT. If you see hemorrhage, if you see a tumor, if you see hydrocephalus, then clearly there's not acute stroke. You have another explanation for this, and then there's a different sort of algorithm to work those patients. However, if you see a dense vessel sign, if you see gray-white differentiation loss, then you are dealing with an acute stroke. This patient will be followed by, immediately on the same table, we'll inject contrast and we'll do a CT angiogram. Okay? And at that time, we make a decision, are we going to do a CT perfusion or not? Okay? And that decision really based on, can the patient get MR perfusion, or has the patient consented to some of these special studies that are undergoing? So the patients who cannot get MR perfusion will routinely do CT perfusion on them. Okay. Then they move on to the MRI side, where if they can get an MR, we'll do a diffusion-weighted MR sequence. In certain patients, if CTA has been done, we'll typically not do the MRA, and if the patient is MR compatible, we'll do an MR perfusion. Okay. And using all this data, then we triage the patient. If the patient is within 3 hours, we'll give IV TPA. Within first 6 hours, and these numbers are not hard and fast. There is a little bit of patient-by-patient variation here. We will do IA thrombolytic therapies or embolectomy, and then after 9 hours, there are very few options that are available to you. Things like hypertensive therapy, hyperbaric oxygen, and stuff like that. Okay, so this is our single slab perfusion protocol. You use very low kV, and it's been emphasized a lot that lower kV is better. Earlier, we actually this is an older protocol. We have changed this number to 150. Okay, and to further reduce the dose, we use a 1 second rotation time. We use an 8x5 millimeter coverage, and typically, which vascular territory is involved. So a single slab is sufficient. Okay, and then we acquire the data for that slab using these two phases. In phase 1, we acquire one image every second. We are rotating every second, and we are reconstructing it every 5 seconds, an image. And in phase 2, which is an axial scan, we acquire an image every 3 seconds. So early on, when the bolus is coming in, we are doing fast imaging, and later on, we are doing slow imaging when we are in the venous phase. So the total duration is about 67 seconds, and the total X-ray exposure time is about 49 seconds. Okay. The CTDI volume is about 470 milligray, and the DLP is less than 2,000 milligray per sievert. And the overall dose that you get, the skin dose is what is the main question here. The skin dose is well within 0.5 gray. Okay, and you can further reduce. There is actually, these numbers should be modified by about 25% because we have gone down to 150 mAs. Okay, here's an example where the patient came in. This was the infarct. This is your MTT. So this is pretty much the tissue at risk. You see the tissue at risk is much bigger than the core of your infarct. The patient went on to angiography. We saw a cutoff in the MCA here. This is the early on in your session, and then so you go through, use a Mercy retrieval device, or there are other ways of putting TPA within the clot. There are multiple ways of retrieving this clot, and then you open up this artery, and this is the scan a week later. There is slight interval increase in the degree of infarcted tissue, but it does not cover the full area that was at risk. Okay, so this patient was helped by the fact that we knew early on that there was a diffusion-perfusion mismatch. There have been trials, a diffuse trial being one of them, where they have shown that if there is a diffusion-perfusion mismatch, and if you are able to reestablish the blood flow, then you have good outcomes. If there is no diffusion-perfusion mismatch, and if you try to attempt therapy, you may do more harm to the patient than good, because TPA and so on, all these things have associated risks with them. Okay. Obviously, CT dose has been a major concern. Everybody wants to avoid this particular situation. This is an image from a few years ago where somebody got alopecia just in the distribution of where they got their perfusion scans. Okay, there has been an FDA advisory. So let's talk a little bit about dose. We should keep as low a kV as possible. 80 kV actually works quite nicely, and in fact, it's good. It's a better setting than the higher settings like 100 or 120 kV, because the iodine, which is what you're looking to quantify, is more conspicuous. There's less radiation, and there's less dose associated with 80 kV. Okay, low MA is sufficient. One can use 150 MA, which is what we're using, and it works well. There was a paper that came out as low as 100 MA per rotation has been suggested. The dose at which you get epilation is about 3 grays. So you are well within the dose at which you will the hair would fall off. This table sort of nicely summarizes how the dose changes when you go from 80 kV to 140 kV, and as you can see, there's a large magnitude of difference when you go from 80 kV to 140 kV. So the basic message here is CTP is a sort of evolving. CT perfusion for neuro is an evolving modality. I think we can do it well within the dose. So to me, in the right hands, dose is not the right concern. The right sort of questions to ask is how are we going to use this data clinically, how are we going to standardize across vendors, how are we going to come up with these thresholds below which we'll intervene or not intervene. Okay, let's talk a little bit about cardiac perfusion. Everybody talks about the ischemic cascade where there's a perfusion. This is a short axis view through the heart, and then I don't know if it shows up, there is ischemia in the anterior anteroseptal and anterolateral side of the heart, which starts off metabolic disorders. There's a diastolic dysfunction, then there's systolic dysfunction. You get EKG changes. There is chest pain, which is the symptom most commonly associated with it, and then it progresses into myocardial infarction as a function of ischemia and time. Okay, CT can show you. It can intervene at the very early stage. It can show you potentially the perfusion defect. It can potentially characterize the plaque. It can show you both the diastolic dysfunction and the systolic dysfunction, and it can actually show you the myocardial infarction itself. Okay, so the CT actually is a fairly good modality for assessing cardiac perfusion. Okay, the reference standard is nuclear medicine. These scans tend to be very high dose. It's not talked about for some reason, but these scans can be as high as 25 millisieverts. Okay, but that's what the reference standard is, and they are very artifact prone. So here there's the stomach bubble, which is bright and is sucking up photons from, and also there is there can be a defect in anteriorly or posteriorly. The posterior defects are from diaphragm. The anterior defects can be from artifacts can be from breast shadow. So all these these are very artifact prone, and some of these things can be addressed by a cardiac CT. So when you're considering a stress perfusion CT for heart, there are several questions one need to address. Okay, what is the stress agent that we're going to use? What contrast at what dose, what timing, and what's the rate? What is the CT protocol? Are we going to do prospective scanning, retrospective scanning? How are we going to do the scanning? And how the image analysis is going to be done. Okay. So here are some of the agents that one can use for cardiac perfusion, for stressing the myocardium. Exercise is obviously free, but it can cause a lot of motion. Dobutamine has been tried. We use adenosine, which and primarily because it gives you only mild tachycardia. The heart rate doesn't pick up after you give adenosine, okay, which is a plus when you're doing cardiac CT because you want a low heart rate. And when we are doing this, we do not give beta blockers because then you're sort of contradicting each other. Okay, and then these are some of the other modalities, other pharmacological agents. This is the protocol that we use. And there are multiple variations of this possible. This is what we have used, but I'm not by any means saying that this is the protocol that everybody should be using. Okay, so we do our stress test, imaging before we do the rest imaging. Okay, and the stress imaging is with a contrast bolus of about 60 to 80 cc's at 4 cc's per second, and at that same time adenosine is being given, and that is a retrospectively gated scan. Okay, and then we allow the patient about 5 minutes of rest time. The myocardium recovers, and then we do the resting scan, which is done prospectively. Okay, so this is a very low dose scan. Okay, this scan may be 7-8 millisieverts. This can be like 1 to 2 millisieverts, and then we do a 10-minute delayed scan to see if there is a delayed enhancement of the myocardium, and that is also a prospectively gated scan. Okay, all these images are co-registered. So here we have a stress image, here we have a rest image, and I don't know if you can appreciate, there is a subendocardial hypoattenuation here. That means this, under stress, this area of the myocardium becomes ischemic. Okay, and in the delayed scan, we don't have any enhancement. That means there is no scar tissue or there is no hibernating tissue. While reading these scans, one should be cognizant of some of the artifacts that can arise. It was described very nicely as to how these different slabs are being acquired at different times, and that can give you artifacts. For example, here there are some slabs here that are running, and that is not because there is a perfusion defect, but because that's a slab artifact, and you just have to sort of learn to read through those slab artifacts. There are other types of artifacts. For example, is this myocardium really ischemic? Is it underperfused? Is this myocardium underperfused? Then you realize, well, there's maybe a line running through here, going all the way up there, and then there's an EKG lead there. So in between two objects, so there's a bright aorta here, and there's a bright lead there. In between, you can get these photon starvation artifacts. Okay. There are certain newer techniques in CT perfusion that are coming up. We alluded to all these iterative reconstruction techniques in the previous talk, and there's the dual energy imaging, which is also promising. So here is a iterative reconstruction algorithm. It's a homegrown algorithm. Homer Pian and Sinho Do, who gave me this slide, have developed this model-based technique where if you do the regular filtered back projection, you can see that there is a little bit of an artifactual hypoattenuation here that may be confused with a perfusion defect. However, that goes away when you do an iterative reconstruction. Okay. We have also tried dual energy imaging. So here is a patient, 50-year-old male with chest pain, 7 years status post an MI. There was an LED stent that was placed. That's the stent that you can see at the cross section. What you see is that this myocardium here is thinned out. All this myocardium is very thinned out. And also there is a lot of hypoattenuation within it. What that tells us is that there has been a prior infarct and there has been fatty infiltration of the myocardium because of that prior infarct. Okay. So when you do energy scanning, and on the delayed scan, you can see that there is enhancement within this myocardium that is infarcted. And that has been well characterized in MRI. What we are showing you here is that it can also be seen on the iodine map using dual energy scanning. So I'll conclude with these thoughts. CTP is an exciting area. It's still, in my opinion, somewhat of a research topic rather than a day-to-day routine clinical practice thing. There have been a lot of buzzwords that have come out, a lot of phrases. Time is brain, time is muscle, mismatch is brain, mismatch is whatever. Nobody really knows how to use it still. So CTP is challenging. There are many technologies. There's low SNR, as I showed you. There's potentially high dose. These problems are addressable. I think where the effort has to go in is in more research in establishing the bounds on where it is usable and how can we use it. Okay. The complexity can be managed. Low KVP is recommended for all CT perfusion imaging. There is another thing which actually I did get into details of is there are multiple scanning protocols that are available which have different resolutions. There are the shuttle modes where you go up and down and you can get an image every 3 seconds. What you have to keep in mind is what is the Nyquist limit of what we are trying to image. Brain has a very fast circulation time. The transit time through the brain can be 3 seconds to 5 seconds. So obviously you have to you have to be operating at the Nyquist limit. So you have to acquire a sample at twice the rate of that. So anything which is 3 seconds or over would be a non-starter in my mind for CT perfusion imaging of the brain. Okay, you have to remain within the Nyquist limit. Okay. Do not truncate the timeline. That is another artifact that we've seen. If you don't acquire the data long enough, then you don't see the bolus completely go through, and you will never know what your mean transit time is. Okay. There are many new promising developments. Iterative recon being one, and dual energy imaging being the other, and both of them are still being sort of worked out as to how we're going to use it. So I think with that I'll stop, and I'll take any questions.
Thank you very much. Do we have a quick question? We are doing very well on time. I want to thank everyone. Looks like people are anxious to take a break. Now, there's a slight typo. I noticed the break says from 3 p.m. to 3:30 a.m. So how about we convene? We'll convene at 3:30, but let's take one question first, please.
And this is actually for Dr. McCullough, but the CTDI vol that we get from slab brain perfusion, do we interpret that the same way as we would a CTDI vol of the entire brain?
That's a very good question. The CTDI vol is a metric which assumes contiguous or overlapping and some sort of the table is moving type of scan. And that is not what's happening in CT perfusion. So if you do some measurements, we've done this. The CTDI vol overestimates the skin dose by about a factor of 2. So actually there's a factor of 2, conservatism, if you will, but that is recognized, and we are working to fix that. But so if the CTDI vol says, 0.5 gray, it's really only half of that's the skin dose. Okay, so faculty will be around, but otherwise please enjoy the break, and we'll be back at 3:30.